Thank you, ladies and gentlemen. It's very kind of you and nice of you to come here on a Sunday evening for to hear the lecture by the gastroenterology. I should introduce both the speaker and the subject. Dr. Arun is a well-known gastroenterologist, and the younger gastroenterologist. He is the rising star gastroenterologist in Chennai circles. He is highly qualified, very excellent in endoscopic skills. He is now consultant in number of hospitals as well as in Kilpauk Medical College, Department of Digestive Health. Now, these two terms you are familiar. Dyspepsia is, of course, a very old term. Even when in medical school we have been taught about dyspepsia. This means difficult or disordered. Dyspepsia means digestion, that we all know. But the other term, dysbiosis, is fairly recently introduced. Now the concept of internal microbiota. There is a lot of billions and billions of organisms in our system, especially GI tract. And when something goes wrong with this internal biometa, so things can go wrong, and they are also important in health and diseases. And this is what our learning will tell us.
Thank you, sir, for your very kind words and respected all. It is a great pleasure for me to be in this wonderful evening. And I would like to thank Torrent for giving an opportunity to discuss with you all. And before taking on the discussion, one very common, simple topic to analyze the concerns, but when you're going to manage a patient in your clinical scenario, it's very difficult. Because most of the patients will be coming to the primary care physicians, and once a patient, later the patient will be coming to the gastroenterologist. And all the physicians or surgeons every day, in and day out, will be seeing this kind of scenario. So most of the patients, either male or female, will be presenting to us with evidence of dyspeptic symptoms. What do you mean by dyspeptic symptoms? Nothing but if there is any evidence of indigestion which is going to happen in your stomach, in your GI tract. So indigestive symptoms, as we are well aware that the common indigestive symptom will be heartburn, you might be having chest pain, you might be having bloatedness, you might be having heart and bowel habit. These are all the characteristic common indigestive presentation. Once a patient is going to land up with this kind of events, we need to strongly analyze what is the etiological factor for this patient to land up with this kind of event. My intention is not to talk each and every slide, and before we are going to wind up, very simple mechanism how to identify the pathophysiology, how to recognize the patient is having evidence of dyspeptic symptoms. In the background of dyspepsia, whether we are going to tackle with any evidence of organic etiology or whether we are going to tackle with any evidence of functional etiology. This is very important because nowadays functional GI disorders, a separate entity, has been taken over the field of gastroenterology. So starting from your head to foot, starting from your oral cavity, from your esophagus, from your GI tract, from your gastroduodenum, from your large bowel and up to your colonic mucosa and your biliary tract, your pancreatic region, there are a huge list of functional GI disorders are there. And apart from that, starting from your infancy, right from pediatric age group, adolescent, middle-aged and older age populations, there are a huge list, more than 20 to 30 functional GI disorders being recognized so far. As per the Rome guidelines, what they were mentioned. Now, the latest Rome 4 guidelines have been taken on, but as per that, more than 20 functional GI disorders have been there. So, how to recognize the presentation briefly, how to understand the concepts, how are you going to tackle, how are you going to recognize the patient having an organic focus? That's the most important thing. We are not supposed to forget when you're going to manage the patient with dyspeptic presentation. So, this is the basic approach. We should not forget. It's more than 30 to 40% of the population among the global population will be having evidence of this FGID. In FGID, most of the population will be women because women will be easily affected with this kind of functional GI disorder. As you all know that by any factors which is going to prevail, it's not only based upon your gastrointestinal tract, it's also based upon your mind. That's what's called gut and brain interaction, your GABA receptors. All those things is going to get involved. Any dysfunction, if it is going to get active in your gut, so if your mind is happy, your gut will be happy. If your gut is happy, your mind will be happy. So if there is any dysfunction, if it is going to be there is high possibility for you to land up with this kind of GI. So how to recognize more than 40 to 50% of the population nowadays in global ratio so been identified with this FGID. Among them, women are more common, and as the age increases, the ratio, the evidence of FGID is coming down. So it's more common nowadays in younger population. For example, routine practice daily, most of the IT persons who will be even after this COVID scenario, for the past 4 to 5 years, we have been seeing many patients been suffering with this functional GI disorders. Today morning, I have seen a patient who had evidence of persistent chest pain, reflux, irritation, persistent bloated. He is such a young male, just 25 years, recently married, but who presents to us in this background. So how to recognize whether the patient is having illness, whether the patient is having sick presentation, how to counsel, how to manage, that's the most important scenario, that's the most important thing we should not miss when you're going to manage with this kind of functional GI disorder as a physician or surgeon in a routine practice. That's the most important thing. Before winding up, I would like to convey to you all. And it's most of the time, see, as you are well aware, if you are going to have some findings, if there is an organic pathology, it's easy to treat. But if there is no organic pathology, if you're going to do endoscopy, if you're going to do basic workups, all GA workups you're going to do, that doesn't yield any major picture. So how are you going to approach such kind of patients? You're going to start the patient on basic medication, but finally the patient is not going to respond. They'll be having frequent doctor shopping, they'll be going here and there, and the symptoms is going to keep on worsening. So how to recognize? So diet manipulation, lifestyle, right from the intra-uterine age group, right from the broad term, all those things is being component of your functional GI disorder. So your environmental factors, your ethnicity, your group, your relation, all those things. So the environmental component is the main triggering factor. Psychogenetic, psychological concepts. Suppose if you are suffering from anxiety, if you are depressed, if you are more depressed, if you are having more somatization, if you are having any neurological events, that is one functional GA event supposed to be taken on. And apart from that, your GA event, suppose if you are a chronic alcoholic, smoker, coexisting presentation, or if you are going to have any other event, for example, if you are going to present with irritable bowel, type C or type D, constipation or diarrhea predominant, if you are going to have an immune system alteration, if you are going to have any gut dysbiosis, that's going to take off. So all these things will have an impact on your GI. So that is what is very difficult to recognize. Huge list of molecules in the market when you're going to try, but how far it is going to be successful when you're going to use for this patient with this molecule, is it going to respond or not, we are not very sure. So that is why the FGID tackling is one very complex scenario, and nowadays is one of the booming area in field of gastroenterology when you're going to assess, when you're going to manage, when you're going to recognize a presentation in early age, early events of onset. So the basic presentation, any events FGID, the patient will be having characteristic pain, predominantly in the epigastric region. In that, the basic definition will be your epigastric pain syndrome or postprandial distress. You are going to take your food. Most of the patients will be a type 2 diabetic, obese male patient who presented to us in the background of bloatedness. So how are you going to recognize that? You might be having bloat, nausea, fullness, you're vomiting, erectations, aerophagia, so many presentations starting from your chest pain, function chest pain, all those things will be there with your halted bowel habits. It might be constipation predominant or diarrhea predominant or mix of component. One day the patient will be having diarrhea, next day will be having constipation. So if you're going to tackle your diarrhea, next day the patient will be coming to your clinic with evidence of constipation. If you're going to tackle the constipation, next day the patient will be having evidence of diarrhea. So this is the ratio you need to tackle. Which is the predominant symptom? How are you going to recognize? How are you going to manage? Counseling, diet, lifestyle, elimination of risk factors. All those things will be taken on a predominant role when you're going. Even psychological concepts is very important. Managing with other antidepressants, TCA or SSRI, to whom you're going to consider. All those things is important when you're going to tackle your functional GI disorder. So the basic thing is difficult digestion. So various symptoms, as I discussed with you, predominantly around 40 to 50% will be having evidence of functional GI. As of now, 60 to 70% they have improved, and only 30% of the population, as the age increases, will be having evidence of organic focus. For example, your malignancy, your peptic ulcer, and other diseases events will be going to take on. But apart from that, you should remember the basic things and basic concepts. So functional GI disorder, you should not get confused with two main entities. One is base peptic ulcer, and apart from gastroesophageal reflux. These two are very entirely different when you're going to tackle with your functional GI disorders. So the basic pathogenetic mechanism will be, So you list, so you're going to take your food, your gastric accommodation if it is going to get altered, your intestinal motility if it is going to get altered, and in case if you're going to land with evidence of H. pylori infection. That one simple thing I have seen in now routine practice, that too in western northern parts of India, we'll be having frequent H. pylori positives. They'll be having urine tests, they'll be having serum antigen, every time they'll be doing H. pylori assessment, and many of the patients being treated with H. pylori medication. After 14 days and all those things, the symptoms are not going to respond. So they may have positivity. Frequently we are seeing in a routine practice, and the patient comes and questions us, sir, I have been treated with the medication for 14 days of your H. pylori regimen, but even after that my symptoms are not responding, my clinical presentation remains the same, and my blood serology still shows to be positive. So hopefully you are going to recognize there is no single pointer to diagnose your Helicobacter pylori significantly. Even if you are going to take endoscopic biopsy-based interventions, the sensitivity ratio will be only around 70 to 80% of the population. So there is no single proper operation to diagnose the H. pylori. So how are you going to recognize to whom you are going to start? How are you going to assess the red flag signs for your dyspepsia? This is one of the characteristic scenario we should not forget. And your visceral hypersensitivity. Most of the patient will be having pain. Your pain, sensitivity, they will be having always irritability. And your psychosocial, genetic, and one important thing, some concepts have been proven based upon your digestive enzyme. As you all know, there are huge list of digestive enzymes, starting from your amylase, which is being predominantly involved, trypsinogen, your papain, all those things based upon your various factors, the bile acid, the composition, your pancreatic secretion, all and your gastric secretions, all those things is going to involve a proper homeostasis has to get maintained. And in order, if the patient is not going to maintain a proper homeostasis, at that point of time, you may subject the patient with digestive enzymes. But doesn't mean once the patient is going to get subject to the digestive enzyme, the patient's symptoms is going to respond completely. Assessing the presentation is very important before you're going to tackle any event. And the characteristic discussion is, as I told you, more than 70% of the patients, the basic pathophysiology is always very complex and multifactorial, and this is all the basic things what have been discussed. Your gastric and various gastric accommodation, your emptying. For example, if you are type 2 diabetes, gastroparesis, nowadays so many innovations being happening. You can do your electrogastrography to state your gastroparesis. So many patients will be reporting with it. So they'll be taking your food, even after 6 hours, the food will rechange in the stomach. Most of the patients, morbidly obese, gastroparesis, the patients having BMI more than 30 to 35, at that point of time, the patient will be having more gastroparesis. We don't know what is the reason. So these are all the events you need to assess, and as I discussed, your various digestive enzymes, pancreatic insufficiency, so many compounds are there we should not forget. And one important entity is gut dysbiosis. As you all know, starting from right from your intra-uterine period, your child, the elderly population, the gut microbiome is a separate area. That has been considered as a separate human genome. It's been considered as a separate organ system nowadays. So more than trillions of organisms. So the one which encompasses the gut microbiome is different, and gut microbiota is different. If there is any problem, if it is going to cause any dysbiosis, if the gut microbiota normal commences, if it is going to get perturbed, at that point of time you are going to land up with evidence of the condition what is called a dysbiosis. So how to prevent that? You need to maintain a proper eubiosis. The eubiosis has to be there, the proper organism has to maintain. So if you're going to take a medication, for example, the common medication in a routine practice, we are going to use a proton pump inhibitor. If you are going to use a proton pump inhibitors for a duration of time, that itself will predispose to your gut microbiota alteration, that itself will be having a strong worsening, and there might be evidence of your various risk factors to progress. So you need to be cautious to whom you are going to use your PPI, when you are going to subject the patient with PPI. All those things should be strongly addressed if you want to manage the patient with this kind of scenario. And next to that, the common two conditions is postprandial distress and epigastric pain, nothing much. You should not forget, both mimics the same event. As we are well aware, the postprandial distress is very good molecules being added. For example, your acetoshimate, your acetylcholinesterase inhibitors. If you are going to use that, for example, your muscarinic pathway is going to get blocked. At that point of time, there may be evidence for your functional abdominal pain syndrome, your postprandial distress. There is possibility for you to have a reduction of your presentation. So these are all the basic things. How to diagnose There is no single entity to diagnose any common characteristic GA presentation. But based upon your cardinal symptoms, a proper history taking, proper assessment, proper gathering of the routine anthropometry, proper gathering of your BMI status, nutrition, coexisting comorbidities, the diet, lifestyle, psychosocial, all those concepts you are going to assess when you are going to manage. Assessing the history is very important. And four major things: early satiety, postprandial fullness, epigastric pain, epigastric burning. And you should not forget there are always red flags. Without red flags, gastroenterology will not flourish. We should remember there are certain red flags. Commonly, you should not forget any patient in any age group who presents to us in the background of persistent vomiting. It's a characteristic red flag. Second, if you're going to see any mass or lump, red flag. And if the patient is going to have a significant weight loss, for example, more than 10% of your body weight is going down, you need to be very cautious. And fourth, patient who is having bloody events, for example, even upper GA, lower GA, any bloody events, you need to be very cautious. And these are all the characteristic red flags you should not forget, which is uncommon when you are going to manage a functional GA disorder. You are not going to exhibit, but even then the patient will be having all sort of presentation. So we haven't seen few months for example, I would like to state a scenario. A 65-year-old male who presented to us in the background of altered bowel habit. The diet pattern mimics spurious diarrhea, which means he might be having evidence of constipation and the stools will be coming in a little bit manner. So that patient being treated at IBS for many months in various centers. Recently we have seen, and we have just placed a colonoscopy, we can able to identify a prominent mass in our colorectal region. So why I would like to point out, if you are going to think a patient is irritable bowel, that might be evidence for you to handle with colorectal cancer. So recognizing the presentation, analyzing the event is very important when you are going to manage, when you are going to tackle any evidence of any patient with upper GI or lower GI symptoms. And as you all know, common foods, if you are going to take high carbohydrate diet, high fat load, even some patients you are going to have high FODMAP. What do you mean by FODMAP? Fermentable oligosaccharides, disaccharides, polysaccharides, these things you should be very, very careful. I would like to state, if you're going to use fruits also, for example, there are certain diets, certain fruits you can advise for the patient with diabetes, but that kind of certain foods also will precedent based upon your lactose, sucrose and fructose content. You need to be very conscious that may be exposed to lactose, sucrose or fructose intolerance, and at that point of time the patient may have satiety, your postprandial fullness, distress, gaseous distension, because your intestinal bacteria is not going to ferment. That is the production of your SCF, short chain fatty acids. At that point of time, the patient may land up with the evidence of your massive gastric flow. The patient will be having persistent pain, postprandial distress, all those events will be preponderant. So diet, you need to be very cautious to tackle frequent small meal, avoidance of high FODMAP diet. It's very important. We are going to tackle even with IBS in the background of functional GI disorders. This is what the basic thing have been discussed. So if you're going to increase your osmotic load, and what is going to happen if you're going to give high FODMAP diet, the osmotic load is going to get high, that will predispose to formation of more SCFA, and that will predispose for you to have more gaseous bloatedness of your tummy. So diet, lifestyle modifications, your H. pylori eradication, and all those things. For example, if you're going to use PPI, you may subject the patient to prokinetics, you may use H2 blocker, you may use alginate preparations. There are so many lists of molecules based upon to which patient you are going to use, what is the target. If you are going to tackle a lower GI, you can use your laxatives, you can use your purgatives and all those things, along with nowadays the secondary GOMs have been very used. For example, your procolocride, linaclotide, so many molecules are there for constipation. For example, if the patient is having diarrhea, so rifaximin, so many other molecules are there. So huge list of molecules is there in the gastroenterology when you're going to tackle a presentation. And apart from that, you should not forget about your antidepressants to whom you're supposed to subject, your probiotics reasonable, having a beneficial role, for example, starting from your upper GI, non-GI condition. For example, if the patient is having cardiovascular event, nowadays even for respiratory, as you all know, many allergic events they are using probiotics. Even for gynecological indications, they are using role of probiotics. So many other additional beneficial role of probiotic or prebiotic as well as symbiotic. nowadays been improved, and enzyme preparations, if you want to talk on that, huge list of enzymatic preparations are there. And if you want to consider antacids, for example, you add and subject the patient with your enzyme, because it's going to maintain, it is not going to act on any bacterial spores or anything, so it will be very safe for you to get your enzymatic preparation rather than going for your antacids at any point of time. So PPI, very important thing, always you all know the proton pump, the well-known molecules starting from 1980 till now frequently used by all of us for all the conditions. But huge list of molecules are there, starting from a single release filtration, dual release filtration, persistent double drug regimen dose, all those things are being there. I have seen multiple prescriptions, morning one PPI, evening one PPI. These are all the very common mistakes being frequently encountered. You should be very cautious when you are going to use a PPI. As you all know that there are a huge list of adverse events nowadays being reported. For example, if you are having a cardiovascular event, huge list of cardiovascular risk factors, because there is evidence for your PPI to interact with your clopidogrel. For example, if you are going to use your pantoprazole along with your clopidogrel, that will going to act on your CYP2C19 pathway and 3A4 pathway. So it is going to have an interaction at that point of time, which may predispose for your cardiac events, major acute coronary events. In short form, we would like to say as MACE. So these are all the pre-bonding, and you may have bone loss, you may have elderly disease for hypomagnesemia, malabsorption. And if you're going to use PPI, so every center, 5 years, 6 years, in government institutions, every day they will be going, in primary health center, every day they will be going, they will be taking PPI. For years, just like that, they will be taking PPI. And we are going to put endoscopy, you will be seeing multiple polyps. You may be having fundic gland aplasia. The patient will be having evidence of all other complications may get landed. So you need to be very cautious. Nowadays, even for your neurological disorders, even for your chronic kidney disease, interstitial nephritis, so many other complications, adverse events being reported with your PPI. For example, if you're an alcoholic, if any patient tends to be alcoholic, there is high ratio for them to be in the phase what is called alcoholic hepatitis. If the patient is going to be on alcoholic, if the patient is going to land upon alcoholic hepatitis, and if the patient is going for septicemia, and if the patient is going to be in ICU care, and if the patient is going to subject with PPI, that PPI, there are certain case scenarios being there to prove that because of the PPI, the patient scenario will tend to worse, the septicemia will tend to worse. There are so many things these reports are there. So, yes.
Then how to continue in using the PPIs intermittently or continuously? Or
based upon, that's what I would like to say, sir. Based upon what is the area you're going to target, what is the treatment duration you're going to achieve. Ideally, when you're going to start, for example, if the patient is having erosive esophagitis, the duration of treatment should be restricted to 8 weeks of regimen. If you're going beyond 8 weeks, it should be very cautious. You need to maintain maximum 3 months of regimens are there, and there may years of treatment being given there. If you're going to look for erosive, if you're going to put an endoscopy, and you're going to see some erosion, in that you all should remember there are grading systems based upon your Los Angeles, okay? So there are 4 grades. One will be a mucous, I don't know the diagram with me. If you're going to see that, for example, when you're going to use PPI, erosive esophagitis definitely is one of the best molecules rather than your H2 blocker, because your H2 blocker will not have a significant potential role when compared to your PPI once a patient is having significant esophageal erosions. That's a characteristic organic event. You need to be cautious. So stage A, grade A, B, C, D is there. C and D means the esophagus more than 70% will be involved. And A and B means it will be only few erosions, only few lines of erosion will be there. So you need to be cautious. So erosive esophagitis, if you're going to tackle means PPI is very safe. H2 blocker is not much of potential role. But when you're going to use as a maintenance, for example, if the patient is having nocturnal symptoms, night time, once a patient lies on the patient will be having bloatiness in the tummy always. And many patients gets up early in the morning, very frequent belch, and all those stuff. We have been frequently encountered with multiple patients. To prevent that, there's a molecule called H2 blockers. It will be acting on your nocturnal acid breakthrough phenomenon. So nocturnal acid breakthrough, to prevent that, you can combine your PPI with your H2 blockers safely. So why I would like to point out this, we need to maintain our intragastric pH should go in a ratio of more than 4. That's a separate area to talk on GERD, but why I would like to point, So PPI, you need to be very cautious, subject the patient, and you should not go beyond the restricted limits. And when you're going to tackle, assess the patient as a whole. What are the coexisting presentation? The diabetic, obesity, NAFLD, cardiovascular, neurological, Alzheimer's, Parkinsonism. What is the area you're going to tackle? How are you going to manage? It's very important when you're going to use your PPI. Apart from that, few points I would like to state about your enzymes. As you all know, based upon your enzymatic insufficiency, your maldigestion, your various food allergy, your intestinal fermentation is not going to happen properly, or leaking gut, for example, your SIBO, a small intestinal bacterial, there are so many other things that are being reported with that. In order to prevent that, so causes of enzyme deficiency, these are all more simple areas, as you all well know, any impact secretion, your diet factors, your diet choices, your age factors, all those things. But you should not remember certain things when you're going to manage with that. There are a huge list of enzymatic actions. The first one is based upon your diastase. As you all know, for example, in your unique enzyme, if you're going to take, it contains peptide, charcoal with your diastase, for example. And what you're going to have, it is going to produce a sufficient enzymes which will be acting on your pancreatic bile and other pathways. At that point of time, your lipid digestion, your protein digestion, your carbohydrate digestion is going to enhance in a safe way. So that's why the digestive enzyme is going to have a potential role to certain patients, but it is going to have a reasonable benefit in your GID when you're going to target your bloat as well as your belch. But even then, when compared to your antacids, enzymes are playing a reasonable beneficial role, but doesn't mean that you should do only enzymatic support. Assessing the patient as a whole, one thing I'd like to point out to you is very important when you're going to tackle such events. So this simple diagram, I would like to flowchart, I would like to show it to you, because antacids, alginates will not act on your erosions. As you all know that your gastro, and if you're going to put, suppose if your patient is having severe reflux and you're going to do endoscopy, a gastroenterologist will be reporting to you the patient is having normal endoscopy. Doesn't mean that the patient is not having reflux, because as you all know that the condition non-erosive reflux, this is a separate entity, and that condition as per your ACG, your American College of Gastro guidelines, what you mentioned that more than 70% of your population will be having non-erosive reflux. Only 20 to 30% will be having evidence of reflux. So you need to be cautious at that point of time. Non-erosive reflux, when you're going to tackle, antacids some beneficial role, but once the patient is having erosions, there is no role for antacids, there is no role of any beneficial effects of that, and very short lasting and multiple other complications, aluminum intoxication, magnesium intoxication. Few reports are there, so you need to be cautious when you're going to use your antacids when compared to your digestive enzyme. But there is not much of significant side effects of your digestive enzyme, but that is also one significant impact you should assess if you are going to tackle a patient with irritable bowel at that point of time. For example, if the patient has diarrheal predominant IBS and they have seen some prescription of digestive enzyme, so that patient will be having worsening of events. So you should be very, very cautious to whom you are going to subject, to when you are going to subject, what is the treatment, what is the predominant area of affected organ system in India. You need to be cautious that you are going to manage a patient with this kind of scenario. And this is what the simplified approach: determine, assess the patient, and with no major organic focus being identified, consider the patient as functional GI disorder and look for whether the patient is having predominant upper GI or lower GI. As you all know, huge list of areas, more than 20 disorders are being there in functional GI, so you need to be cautious to assess and manage. And something I would like to state on dysbiosis is, you all know that what do you mean by gut dysbiosis? See, one thing, the microbiota, if it is going to get perturbated, then you are going to get your gut dysbiosis. There are a huge list of conditions. Basic conditions you should not forget. Basic thing will be your acute gastroenteritis. In that, what is going to happen? Huge list of causes are there. One is because of virus, bacteria. Starting from your pediatric age group, the commonest virus will be your rotavirus. So what is going to happen? Once a patient is going to have a rotaviral event, 70 to 80% of the cause will be because in the pediatric age group because of your rotavirus. And next to that, in adult population, your bacterial diarrhea. For example, E. coli and Shigella, blood events, all those things will be there. So in these areas, there is evidence of your gut microbiota to get collapsed. So basic gut microbiota, for example, your Firmicutes, the basic one, your Faecalibacterium basic, and very common area we should not forget is your IBD, inflammatory bowel disease. Because two major entities are there. One is by ulcerative colitis and one is by Crohn's. to recognize, to manage, to assess is very difficult. In those entirety, the gut dysbiosis is one of the most common events, and there is no single proven etiological factors identified for your inflammatory bowel disease. So gut dysbiosis has been considered as an additional hypothetical concept for tackling your IBS. So, IBD, inflammatory bowel. What do you mean by ulcerative colitis? Any lesions predominantly involving the lower GI. Your Crohn's is still more complex, right from your oral cavity to anal tract, anywhere, any region, the patient is going to have extensive presentation. At that point of time, the gut dysbiosis is definitely strongly to get established. And third one is your irritable bowel syndrome. Very characteristic presentation. So IBS mixed will be 30 to 40%, IBS diarrhea will be 30 to 40, and IBS constipation will be around 20 to 30% of the population will be there. So once the patient is going to have this kind of event, the commonest thing will be your pain, your epigastric, your bloatedness, and pain will be the characteristic presentation of as per your Rome criteria. And second thing, there may be a frequency of your stooling. So frequency change of the stool pattern will be there. And the third component for your IBS will be your consistency of the stool. Either it could be hard or it could be soft. There may be a variable consistency of the stool. These three criteria are supposed to be there for a period of 2 to 3 months, has been proven to prove that the patient is having irritable bowel syndrome. And to tackle IBS is still very, very complex. Even for the best of gastroenterologists to manage that condition, there is a complex entity.
The role of gut nervous system in terms of sympathetic and parasympathetic effects, both the functional as well as other disorders you are explaining. What is the role of the nervous system?
So gut microbiota, the main thing, gut microbiota, the concept being mainly derived from your sympathetic and parasympathetic for based upon your all the areas. For example, starting from your HT4 pathway, starting from your toll-like receptor pathway, all those things is going to tackle on your sympathetic and parasympathetic. If these things is going to get under, for example, in the patient, that's what, even in neurological conditions, very important, the neuro, because gut and brain axis is very important. That's very area, separate area to discuss. And the GABAergic pathway is going to get depleted, and your ACH, so many other mechanisms are there. So you list to analyze the concept, to understand the mechanism is still more complex phenomenon. Why I would like to point out if there is any perturbation in your sympathetic and parasympathetic, for example, if is identify a condition like a Parkinson's or Alzheimer's, any neurological dementia-oriented conditions, at that point of time, the gut dysbiosis is going to get a strong preponderant role. That is why when you are going to manage, it's very difficult to tackle such scenarios. So always there is a relationship with your sympathetic and parasympathetic when you are going to manage a patient with not only for IBS, anything which involves your gut and brain, that has been separated by the separate organ system. That's why it's still more complex to understand the nature of the condition when you are going to treat. So.
Thank you.
And this is what the normal intestinal microbiome. So starting from your oral cavity up to your, for example, your right side of the colon, left side of the colon, and for example, if you're going to look for esophagus, your stomach, so your list will be there, and your right side of the colon will be having slightly more preponderant of your normal gut microbiome which you analyze when compared to your left side, and this is all, the view list will be there, and apart from that, the basic conditions, mainly for example, in the pediatric, in the newborn period, that in that point of time, the mother's intrauterine womb itself, the baby will be having evidence of your microbiota to get formed. At that point, for example, if the baby is going to deliver through vaginal delivery, or if the baby is going to form through LSCS, what is the environment they're going to maintain? What is the nature? Whether the baby is going to be breastfed or formula fed? All those things is going to influence your microbiome. So that is what even the basic hypothesis, for example, your Ford hypothesis or hygiene hypothesis, so many other concepts are there. In that area also there are so many considerations when you are going to tackle. So the huge list will be there. The common things, if you are going to take too much of sugar, and if your pH, if it is going to get altered, your fiber intake, your probiotic intake, your protein consumption, your PPI, for example, if you are going to use long duration of antibiotics, and when you are going to use prolonged duration of your NSAIDs for your ortho regimen, so many patients will be having your gut dysbiosis. You need to be very conscious when you are going to tackle. As I discussed, huge list of molecules are there, and trillions of organisms been identified, and in subgenera more than 100 genus species been recognized when you're going to manage, and the basics, if any perturbation, for example, starting from your NAFLD. It's very characteristic presentation. Nowadays, many obese patients in India and compared to the westernized population, even in southern parts of India, so we are having many NAFLD case reports of that. So at the point of time, obese, fatty liver, the patient is going for NAFLD. So there is high proportion for that kind of patients to land up with evidence of gut dysbiosis has been proven. And once your gut dysbiosis, if it is going to establish, the prevention, the mechanism of your worsening of NAFLD is definitely going to have a significant impact based upon two major responses. One is called as PAMP, one is called as DAM. What do you mean by PAMP and DAM? Nothing but a pathogen associated response, and next one is damage associated response. Those things are not in slides, but what I would like to say, you should remember certain concepts when you're going to manage. Alcoholic hepatitis, based upon your lipopolysaccharide, your PAMP and DAM activity, all those things, there is a role of your gut eubiosis, and once the gut eubiosis is going to go down, that's the area for your gut dysbiosis to take on. At that point of time, the patient is going to have worsening of events. And the basic things is very commonly used. For example, if you underwent a travel as even, travel as diarrhea, high sugar, high level of fructose consumption, and the high level of lactose intake. Apart from that, processed food, junk food, any patient is going to use a prolonged pills for long duration based upon your stress factors, age factors, and your medicines and antibiotics. These are all the areas which are going to have a significant impact. As I discussed, there are a huge list of conditions for your gut dysbiosis, starting from your GI, your other areas, your liver, your cardiac, your IBS, and all those things. This is one of the basics you should not forget, but commonly associated IBS, and next to that your inflammatory bowel, and very importantly probiotics. Probiotics is a separate area to discuss. It's going to have a significant beneficial effect starting from your yeast-derived formulation, or your lactobacillus, or bifidobacterium nigrus, plantarum is considered. Apart from the rotary, so many other molecules. Which area you are going to target with your probiotics is very important, very interesting to discuss. There are more than 20 to 25 mechanisms of action that are starting from your differenzins, your interleukins, tolerant receptors. Your huge mechanisms of actions are there for your probiotic, and you are going to consider, and your prebiotic, which is going to have a fructooligosaccharides. If you are going to add on to your probiotic, that will be a significant beneficial role in your SCFA, in your short-chain fatty acids, and next to that your symbiotic. What do you mean by that? Your probiotic as well as your prebiotic, when you are going to combine, your list of beneficial effects are there. So you need to be very strong in assessing to whom you are going to subject the probiotics, how long you are going to give a probiotic, how are you going to assess the patient for response to the probiotic, starting from the huge list of your probiotic molecules are there. And as I discussed, based upon your probiotic, symbiotic, as well as your prebiotics, you are going to manage the patient. And one important thing, nowadays your probiotics, you need to target the bacterial spores. There are spore-forming bacteria, probiotics are there. For example, your sporogen. So if you are going to give, so the bacterial spore activity in your GI tract, for example, your spore-forming bacteria, if you are going to tackle, at that point of time, your spore-forming probiotic you are going to give, so the beneficial effects will be still more higher. That's what the concepts being going on nowadays. So sporogenes being more considered, and so this spores, they are be resistant to your pH as your bile acid, so it is going to have a reasonable beneficial roles when you are going to use of this kind of probiotics. But very importantly, before I like to conclude, very important, upper GI and lower GI, two major things. Tackling a function GI is a separate issue. Apart from that, probiotics and assessing whether the patient is having eubiosis or going for dysbiosis is very important. Apart from that, considering the coexisting comorbidities based upon the age, various presentation, to whom you are going to target, your upper GI and lower GI, and your liver and other characteristic concepts. Assess the patient's psychological areas, look for the basic ethnicity, and look for the development in all the spheres, and then you can be able to tackle this function GI disorder as well as your dysbiosis can be well maintained. Diet, lifestyle modification, more than 80% of the population should be strongly addressed before you are going to take on with this kind of things. That's the main important thing for me to conclude. I'm very happy to rest this presentation. Thank you for your patient listening. And if there are any questions, we can proceed.
Thank you, Arun. It's very simple because most of the practitioners, suppose you see 10 patients in a day, you may 5 patients will have GI symptoms, and 1 or 2 may have organic problems like peptic ulcer or may have some signs also. But the GI tract is structurally normal. What is wrong is only in the functionality of the GI tract it is abnormal. Instead of passing once or twice a motion, it may pass 3 or 4 times. But whatever test you do, everything is wrong. So that is why so many other mechanisms sir already enumerated what are all the changes you can take. One more problem I normally see, most of us see is, what is the problem? Sir, belching, yapam. This is a very common symptom. And they will demonstrate in front of you, sir, if I press here and get belching. So they will be continuously, when they sit for 10 minutes, they will be continuously belching. This is actually, in my opinion, it's a neurotic disorder, this so-called compulsive, obsessive compulsive disorder. So these patients don't improve with any of these antacids or anything. So I put them on mild dose of tranquilizers. So that settles the matter. So I would like to know
Sure.
your...
Definitely, so whatever you are saying, so most of the concept for a GID to tackle without your tranquilizers and other molecules is very difficult to analyze. And moreover, no single molecules having a significant beneficial role. Frequently we'll be encountering, wherever you are going to touch the patient, most of the time obese population will be having that kind of event. Wherever you are going to press, some patients I have seen, they are pressing even the back and they'll be having frequent eructation. So these are the things you need to address. Very difficult to analyze, very difficult to counsel such kind of patients, and even if you counsel, many patients will not accept, and sometimes the patient will be having a second opinion, third opinion, multiple opinions, but you need to be strong enough to counsel on this area.
One question I always ask is the sleep patterns, whether they're able to sleep. Most of them will say they got disturbed. And most often I resort to actual antidepressants like Prozac or fluoxetine. So antidepressants, especially patients who have visceral hypersensitivity, so-called hypersensitive esophagus. Whatever, how much, even if they give 80 milligrams of PPA, they don't improve. So once you put them on some type of antidepressant,
No, does peptic ulcer produce this belching problem?
But we are not very sure whether the patient is having peptic ulcer. Because peptic ulcer, once you have been diagnosed, it means the patient should be having evidence of duodenal ulcer or gastric ulcer. Whether you are going to
Or
tackle
even gastric erosion or something like that? Do they have
definitely,
this
sir.
problem?
See, most of the patient will be having belching, sir. But we are not very sure that erosion is going to predispose for the patient by belching, to belch.
Because my brother was having, my younger brother was having,
Yes,
and
sir.
he was diagnosed with gastritis. And
I will tell you one thing, sir.
This PPI. This
Sir, I will
this
tell
one
you
has
one thing,
come.
sir. I will tell you one thing, sir. In endoscopy, if you see the report, 90% of the population will be having evidence of gastritis. But if you are going to treat that kind of patient with PPI, doesn't mean his belching is going to get improved. So that's what
But
you
he
need to
got improved,
address.
sir. That's why I'm just asking.
The
this.
belch
my
has-
con-
the
my
belch has-
concept-
Because I was never that thought of it before.
No,
This
if
belching
the
problem.
belch has improved means probably he has been strongly addressed with other components too, sir. Not only on single area, probably psychosocial also supposed to be get addressed, then only all these areas will get reasonable beneficial improvement. Only by the molecule there is no significant potential to do, because diet, lifestyle, your psychosocial, all those things will take on more than 70 to 80%. Only 20% for your molecular benefits.
My concept is, this belching, what is belching? The gas in the stomach is coming out. All of us have gas in the stomach. And why should the gas come out? That means that there is some amount of inefficiency of the lower esophageal sphincter. Once the lower esophageal sphincter relaxes, then only the gas can come out. All other circumstances, suppose the patient after taking food immediately lays down. Because of the heaviness, heavy food in the stomach also, things can get reflect. So along with the gas, there are also other reflexes. For example, acid can reflect, bile can reflect. Many patients will complain of bitter taste. This is because of a biliary reflex. The bile is bitter in taste. So what happens initially, there may be esophageal insufficiency and then belching. then it becomes a habit. This patient tries to do habit. So sometimes when they have difficult circumstances, unfavorable circumstances, these things gets sort of a vicious cycle. It goes on and on. So these are the patients who require sedation, counseling, and you must tell them this is what happens. And then sometimes tell them some small maneuvers. For example, ask them to lie down, turn to the left side, something like that. So that just to distract their mind from this. Patients themselves say, when I'm doing some work, I don't get this. When I'm busy with some work, I don't get this. Only when I'm free, I get this.
For the belching,
When you said the erosion, so when they belch, there may be also acid reflux. That can cause visible erosions.
usually people say bile reflex is more dangerous than acid reflux.
No, it's not. Danger means there is no danger to life, not a fatal disease.
Oh, yeah.
Sir, good evening. Your presentation is very excellent. I have two questions for you. Normally when we give this H. pylori kit, I think Campylobacter infection is missed in most of them. So how will you treat it, or should we consider it or not?
Campylobacter infection, no need to worry about that. Otherwise, there are secondary predisposition for any neurological presentation like a GBS or other thing.
Okay.
Most of the time in GI, Campylobacter jejuni will be resolved on its own spontaneously. No need to address such scenarios. For example, if you are going to chat with your reflux on other molecule, that itself will be taking care based upon your non-absorbable antibiotic or your basic organisms like this.
Okay.
So no need to chat with that Campylobacter jejuni separately,
Okay.
unless and otherwise the patient doesn't going to land with multiple events. And moreover, you are not going to work out for most of the patients for your Campylobacter jejuni
Yes.
in your routine practice. So to think on that as a primary etiology will be most most likely to be not necessary.
Okay. And my second question is in treatment of IBS. Theoretically, they say FMT is advised, but are we practicing it in Chennai?
FMT, fecal microbiota transplant, there are strong role to consider, but in irritable bowel syndrome, it still we need more papers to address. There are two major entities where your FMT has been strongly been proven. One in your alcoholic hepatitis, and another one nowadays being considering in management of your inflammatory bowel disease. But in Chennai, the FMT is definitely not very well practiced as of now. In very few centers in India, they have been considering for FMT. And for example, in managing a patient with alcoholic hepatitis, you can consider once a patient is not going to respond, your FMT has a strong potential role because it is going to alter a gut microbiome. And in very few centers in New Delhi, they have been trying that. Why I would like to point out, Chennai is the best of healthcare, but to address this area, we need more and more patients, even with the patients to target. That's what most of the time it's not been well addressed to target. Yeah.
Because normally for this IBS, young people who come, because it's going to be a long-term course for them. So that is where we advise FMT.
The investment for the patients will
Exactly.
be very high.
Yeah.
So for simple irritable bowel syndrome, in which the patient's psychological components, if you're going to look for IBS, there are four major categories.
Yes.
One is mild, moderate, severe, and very severe. A patient who's going for IBS or very severe, for example, that population will be only 5% in the global ratio. And mild to moderate will be 30-30-30. So why I would like to point out that once you're going for very severe presentation, most of the psychosocial concepts will be going for that. So psychological concepts, your somatization of concepts, all those things, and visceral hypersensitivity is very important. Rather than considering these kind of patients with this kind of molecule in the FMT, addressing the psychosocial component itself will tackle this kind of things.
Okay, sir. And then my last question is, many of our patients, especially elderly age group, so they bring a huge number of pills and they say, I'm taking this, and they're combining with PPI. So what is the advice you would
That's what we need to target whom you are going to treat. For example, any elderly patient, simple thing, obese, they'll be having evidence of type 2 diabetes and dyslipidemia. So they'll be having multiple molecules. Diabetes, they'll be having 3 to 4 molecules. And you are very sure that when you're going to use metformin, that's one of the worst molecules for your GI. One of the best molecules for your diabetes, for GI, the patient will be having, most of the time will be having IBS presentation. So that kind of patients, IBS worsening, the best molecule is always to target with, not with your OHAs, rather than give insulin to that kind of patient to address that kind of presentation. And I have seen seen multiple prescriptions with huge number of molecules. For example, not only a PPI, for other, multivitamins, starting from other preparations, so many other molecules, your neurological medication, there are huge list for if you are going to see in Western northern population, there's still huge list of molecules are there. 10 to 15 molecules will be addressed. I will be telling only to the patients what is the primary indication they are targeting. Treat only that condition and coexisting complication to be addressed. No multivitamin, no multiple other molecules to be given. Most of the molecules are stopped and very restricted, and any patient who is being on this kind of multiple molecules, most of the time I will be choosing H2 blocker rather than giving a PPI, because PPI will have a significant negative impact when you are going to tackle with this kind of presentation.
Thank you, sir.
Ma'am, you raised a very vital question of FMT. See, FMT, it's a very unpleasant method of treatment, and it should be reserved only for life-threatening situations. For example, as sir said, IBD, refractory IBD, or alcoholic hepatitis with encephalopathy. Whereas IBS is a benign condition, it's a chronic condition, probably it has no cure at all. So how many times can you give FMT for? FMT, because of its unpleasant nature, difficult to give, so you should keep it only for situations where to tide over the crisis. Maybe for a benign disease like IBS, I don't think we can give. One more indication is, today morning I heard in the symposium, recurrent Clostridium difficile infection. For that, the FMT is recommended.
Sorry, FMT and what is FMT?
Fecal microbiota transplant.
Oh.
So there are two questions being posted here. How to manage a patient with constipation in gastro? So as you all know, constipation will be a separate entity. Gastroparesis predominantly will be in upper GI. And there is no single entity to prove your gastroparesis. For example, starting from a diabetic, obesity, dyslipidemia, all the patients will be having evidence of gastroparesis. To recognize that, the electrogastrography, if you are going to do that, you can able to identify the markers, the potentials, the spikes to diagnose your gastroparesis. So, but the characteristic presentation will be a long-standing early satiety, your postpartum fullness, prolonged events, and loss of appetite will be the characteristic events based upon your age criteria whom you are going to address. And constipation, always you need to tackle gastroparesis with the prokinetic. So prokinetic is one of the best agents to tackle this. When you are going to use prokinetic, there is some beneficial role for your constipation, no doubt about that. But what is the prokinetic you are going to choose? That's very important. The common prokinetic in our routine practice, the best one is always etopride. Next to that, you can consider using etopride. So etopride, if you are going to target with that, they always will be having a beneficial role to target this. But when you are going to use two prokinetic, for example, in upper GI, you are going to consider your etopride, and your lower GI, if you are going to consider with another prokinetic, for example, your flucalopride, which is secretagogue, and that might be also acting as a prokinetic. So dual prokinetic you may consider, depends upon the weight, age, complications, comorbidities, all those things, but you need to be cautious. For example, you can consider the dose. There are some tracts for your flucalopride, it can be given at 2 milligrams. There are some papers being given for a dose of around 4 milligrams. And always laxatives, you need to be very cautious, not much of load when you are going to use because of the electrolyte disturbances, bloatedness. When you are going to use common molecule, for example, your lactulose, that will predispose always the patient to bloatedness, and the patient will be having evidence of upper GI, patient most of the time will be having evidence of function GI disorders. At the point of time, always to choose a secretagogues rather than choosing this kind of molecules when you are targeting your constipation. And the second question is, if any patient been removed with your gallbladder, so common scenario, the patient will be having dyspepsia, fullness, and all those things. So gallbladder, as you all know, the main thing will be a bile acid metabolism, will be a fatty metabolism, all those things is going to get taken on. Once the patient is going to remove your gallbladder, you need to be very cautious. Always avoid the patient's high fatty meal. Fatty meal has to be restricted, but there is a certain condition, even if the gallbladder been removed, not removed also, the patient may have gallbladder dyskinesia. So for that, there is a separate modality to diagnose. So that's one of the common indications for a function GI disorder. To that kind of patients, avoidance of fatty meal will strongly address. But apart from that, there are some certain molecules, the bile acid resins have not been tried, but still now there is no significant beneficial role for your gallbladder. And same thing what we are tackling with this, counseling, diet, lifestyle will be having a strong potential role rather than considering a single molecule for your patient with evidence of your gallbladder dyskinesia. Any other questions?
Good evening, sir. Some real wise people tell there should be a gap of 7 hours between one meal and the other. Experts like you tell that frequently small meals should be taken. May I know your take on that?
So frequently small meal is always a better option rather than going for a prolonged high level of meal for around 7 to 8 hours. Because frequently, for example, in our scenario like India, most of the patients will be taking alcohol. For example, once a patient is having evidence of alcoholic based liver disease, for that kind of patients also will be advising them to go for frequent small meal. Frequent small meal, if you are going to take, definitely the evidence of postnatal distress, bloatedness, everything will come down, and minimal physical activity has to be strongly enhanced for that kind of patient. Rather than going to take a high diet, one branch of heavy meal, rather than when you are going to take a frequent small meal, definitely having a prolonged, because that gastric accommodation will be coming down. That's one of the strongest pointer, and for your reflex and all those things, as well as your diurnal gastric reflex will come down when you are going to take your frequent small meal. Because if you are going to look for the pathway of your GERD, the huge list of mechanisms of action are there. So starting from your esophagus to your fundus in stomach as well as your diurnal, huge list of potential reflex will be there. So tackling with small meal will be having strong potency, because most of the time if the sphincter is loose, the patient will be having evidence of laxity, hiatus. If you are going to load the patient till here, you will be having more reflux. So always frequent small meal will be having strong addressing events when you are going to tackle such patients.
Thank you.
Saying is pasittu pusi.
Sure, sir.
See, when you are taking frequent this one, how it will be possible? You are not giving the chance for the hunger to come out.
Sure.
So this is a very big question, sir, because over the centuries, what our ancestors were practicing, we have completely changed, isn't it? The way we cook the food, the way we take preserved food, the way we use refrigerators, the way we use all sorts of oily things. So this is what has changed. As Sir says, for a healthy person, sir, as you say, 3 meals is the best. See, in olden days villages, they 5 o'clock they will take some padaisoru and then go to the vial, and then they take some lunch when the wife brings it, and then evening. So they were living a perfectly healthy life. But what frequent means is for people with disordered system. For example, acid reflux, hyperacidity, you can't let the stomach be empty for more than 4 to 5 hours. So we advise some small snacks. That's the difference.
Older people, when they drink liquids, they feel comfortable. When they take solid food, there is some choking sensation or something like that, like esophageal spasm or something like that. Why is it? Is it common?
See, based on what esophageal spasm may happen. That's also one of the characteristic conditions for your functional GI disorder. Because function chest pain, functional heartburn, and esophageal disorders, all these entities will be in characteristic presentation. But you should not forget about one common entity. The patient taking liquids comfortable, but when the patient is having solid saline, more of even you should not forget about motility disorders. Because motility, for example, your esophageal dysmotility, huge list of disorders based upon Chicago classification. So when you are going to look into that, motility disorders will be having more impact. The patient will be comfortable with liquids, some patients will be comfortable with solids. So that is very important. This motility is strongly to be addressed. And this motility itself being considered as a separate entity in your function GI disorder. Not only in that, even for your dysmotility, also for your visceral hypersensitivity. These two major concepts along with your brain and gut interaction has been considered as a separate entity. For that kind of patients also, the same advice, diet, lifestyle, frequent small meals, and look for the precipitating and trigger factors, avoidance of high carbohydrate, high fat. It's always recommended to most of the patients when you're going to tackle.
Actually, I'm delighted from the type of questions your audience is coming. I'm very, very happy. So your question is very valid. See, sometimes when you take food, see the food has to pass 2 barriers. One is the upper esophageal sphincter, so-called tryptophan, and the other one is the lower esophageal sphincter. Dysfunction of both of these is giving a lot of symptoms. So a standard, good advice would be, before starting a meal, please drink some water. Because when you straight away start with a big bolus of food, the upper esophageal sphincter may not relax. At that time, patient may choke, may have regurgitation, and then it can induce esophageal spasm. I myself have got it when you're So please advise the patients to start the meal with a gulp of water. That will prevent this.
questions come?
Any medication to be given for that, sir? Any medication or should be useful?
If motility study, manometry, etc. shows motility abnormalities, then we can try some drugs. There are no satisfactory drugs, maybe new drugs will come. And cerebral spasm has to be, it's a difficult problem to manage.
Diltiazem can be tried if there is evidence of motility. The diltiazem, you nip it up in your hatchet and block the two molecules based upon very complex, even for the gastrointestinal tract itself. But you need to analyze that you are tackling on motility or you are tracking on hypersensitivity or you are tracking on gut and brain. That's a separate area. Thank you very much. Thank you for the great introduction, sir. Thank you for the follow-up. Thank you very much.
I think we had a very useful evening, so well spent. Should thank Torrent. Just one, please, our sponsors, Torrent. There's a molecule there, Visilac GG, rhamnosus, isn't it? Visilac GG rhamnosus. Now, there are many articles claiming the use of rhamnosus has got beneficial effects in most of the motility disorders.
Which molecule, sir?
They have
Lactobacillus rhamnosus disease.
Bacillus rhamnosus, you speak
LRG.
Once again, I want good evening to you all. We have this Torrent Pharmaceutical. I'd like to thank you, your active participant in this evening session, medical session, the dynamic speech of Dr. Varun sir. And I want to thank your this chairperson, Dr. Rajnikant sir also. We as a Torrent Pharma is the largest, seventh company in Indian pharmaceutical field. So we are believers and we are very confident for this, like these sessions, like these medical sessions. In future also we are planning more and more these like these CMEs. So we are expecting you all for this many of other CME also. So once again I want to thank you so much. Thank you. With this, I am welcoming our Ingrasa to give some momentum to the Dr. Chairperson and our speakers. Thank you, Doctor.